So while people come in, I'm just going to introduce myself. I'm Ryan D. McCoy, Director of Sales here at ReelDx. Really appreciate everybody coming in and attending the ReelDx classroom. We're very excited to have everybody here. Dr. David Spiro is going to be presenting. While he's presenting, we would love to have this a interactive webinar. So please utilize the Q&A. Feel free at any time to ask questions. If not, I know David will stop and start asking questions. So let's try to make this as interactive as possible. We're so excited to have you here. And with that being said, I'd like to go ahead and introduce Dr. David Spiro.
Hey everyone, it's super nice. It's a small group today, which is great. I actually love small group sessions, and I don't know what your backgrounds are. Would love for you all to use the Q&A right now and let me know where you are in your training or in your practice. Would love to hear from you. We want you to use the Q&A today. This is like a classroom setting. So, my background is I am a pediatric ER physician, and I'm obviously one of the co-founders of ReelDx. I still do teach as a professor at the University of Arkansas Medical Center and love to teach. I love this format and want to hear from you. So please use that Q&A. Awesome. So PA second year didactic. Great. So Danielle and y'all are in training, which is great. Awesome. Amy, I actually work on and off at Sunrise Hospital in Las Vegas, and the peds ER there as well. I've worked there, so I know Vegas. Would also love to hear where you're from, what parts of the country, get to know you a little bit, and want you to use that Q&A dialogue as we get into the case, because again, we're going to discuss a real patient case and an unknown to some degree. I want to also thank our co-sponsors, Smarty Pants. They're awesome. We've known the co-founder, Steve Pasquini, for a long time. He's one of the most awesome dudes that I've met along the journey. And also want to really thank our other sponsors, POCN and their network. And yeah, so let's see. I am going to talk a little bit about the next slide. So what are our learning objectives today? Our learning objectives, awesome. Ilyaha, I think that's your name, international, based in New York. And Jeff is a AHEC educator in Indiana. I love AHEC. AHEC, we have one obviously here in Oregon, and they're an awesome organization. So in terms of our learning objectives today, we're going to learn about the use of video visual diagnosis as a teaching tool. Obviously, I've been living and breathing this. I don't give any more normal lectures anymore. Everything around my world for the last 10 years has been case-based learning. I like to learn, we'll learn about the presenting signs of intussusception and also learn about best practice. But I want us to think about this case not as an intussusception case, but really as an unknown case. So I'm going to actually get off of the learning objectives and get into the ReelDx platform. So just hold on a second. I'm going to stop sharing that, and I'm going to share my screen and get into the ReelDx platform. So confirming with my co-host, Ryan, you can actually see my screen pretty well?
Yes, if you can scroll up a little bit, then everybody can see it.
Great.
There you go.
Let me expand the screen a little bit. There you go. Can you see that pretty well?
Yes.
Great. So we're going to start from the beginning. This is a patient that presented with acute onset of abdominal pain and vomiting. And one of the things that before I even play the case, I focus on, as a pediatric ER doctor, I walk in the room. I don't use this anymore because we use electronic medical records, but when I walk in the room, I'm actually looking at the vital signs first. I want to know if the vital signs are abnormal or normal in this case. And even before we get into the case, we can actually look at some of the vital signs. And in this case, this child is 12 months old, weighs 7.4 kilos. And for those of you that are not used to weight, typically we think about a 1-year-old being about 10 kilos. So this child is a little bit on the small side. And that's a really just rough, I don't love memorizing. Actually, the best thing to do is to put kids on growth curves if you can. And oftentimes Epic, for example, has growth curve tools that you can actually just plot a child and look at what their percentile is. But as a rough rule, a child a year of age should be about 10 kilos, and that can be helpful. The vital signs here: temp is 99.4, blood pressure is 102/60, heart rate 130, respiratory rate 36, and saturation's 99%. So my first question for the Q&A crowd today is, are any of these vital signs abnormal? Do you think any of these vital signs that we're talking about are abnormal? And how do you figure out if they're normal or not? So those are two questions for you. So while you're answering those questions on the Q&A, which I really would like for you to do, and I would say, I would like you to find one vital sign here that makes you slightly uncomfortable. One vital sign. I'm going to actually play the video. So Ryan, you'll let me know thumbs up, thumbs down, okay?
Absolutely.
If it's choppy or...
All right, so we're here today with Allison's mom. This is Allison. She's not feeling very well right now. Mom, can you tell me what started today?
She had been fine all day, and then all of a sudden she would have bouts of it was kind of like she was throwing a temper tantrum.
Mm-hmm.
You could tell she was in a lot of pain and something wasn't right. And she had been having a lot of bowel movements throughout the day. So that's whenever she was in a lot of pain is when I decided to bring her in.
Was she constantly in pain, or did it come and go in kind of episodes?
It would come and go in episodes. She would be able to be soothed for like a few minutes, and then she would just start screaming again.
Okay. And how old is she now?
She is a year old.
Okay. And she looks like she likes sitting in that position. Is that the case?
Yes, she likes her legs to be kind of tucked up to her belly.
Uh-huh.
And just kind of laid over.
Has she been sick in any other way? Any runny nose or fever or anything like that?
She has not had a runny nose or a fever.
Any vomiting?
Yes, whenever she was in a lot of pain is when I decided to bring her in.
Was she constantly in pain, or did it come and go in kind of episodes?
It would come and go in episodes. She would be able to be soothed in.
Okay. And how old is she now?
Okay. So lot of things here to digest before we even finish the video, but I want to get to the vital signs. So I'm curious what you do. How do you decide if a vital sign is you're getting a sense of the child, you're coming in, you're seeing a little bit of some things. So what are we using? And I'm going to actually go to my bag here real quickly and get my what I use. So what I use, I carry just a few things in my when I walk into a room. Literally, I don't even carry this anymore because we have electronic medical records, although sometimes I have to sign charts. I use this, guys and gals. I use cards. I have it in and there are all sorts of cards you can get. The American Academy of Pediatrics, PALS has cards. I actually have cards from my old and some of my new hospitals. And on my card is a fancy dancy vital sign sheet. Why do I have it here? Because I've been practicing pediatrics for almost 25 years, holy moly. And sometimes I can't remember the exact vital signs for age. So, and I think someone said, Kenton said the respiratory rate seems a little bit low, 36. And someone said the respiratory rate seems a little high. I think Jeff did. And Jeff is actually right to some degree. That's the one vital sign that would pique my attention. So age 6 months to a year, respiratory rate 24 to 30 is the normative range. So 36 would be high. So my gut was that 36 seems high. Heart rate, the mean is about 130. So we're right there. So heart rate is fine. And the systolic blood pressure, upper limit of normal is 89. But lots of different ways to think about that, and we can talk about that. But I actually use this. So the blood pressure of 102/60 is fine for this age. And one of the things to think about with vital signs is what's actually happening when the vital signs are occurring. And if the child is screaming or the child is sleeping, those all could make a difference in the vital sign measurements. I guess the question for the group is, what are the two most common reasons for heart rate to be elevated in a child? What are the two most common reasons for heart rate to be elevated in a child? This heart rate is normal, but what are the two most common reasons for heart rate to be elevated in a child? And Amy says dehydration. That would probably be the third, but there are two reasons why heart rate would, and this is important actually, because you're going to be constantly looking at vital signs, especially when you're managing kids. And I don't need to harp on this too much, but I cannot emphasize to you how important it is, especially early on in your career, to pay attention to vital signs. So I'm hearing infection, again, probably third or fourth reason, but you're close. And I think Danielle and Amy actually said pain, and you're right on. So crying, whether it's pain or just a child is upset, is probably the number one reason why heart rate could be elevated. And the other would be fever. So we see fever a lot in kids when they come into the ER. So that is something to consider. And Jackie was right on, fussy, crying from discomfort and pain. So we have an elevated respiratory rate, and that could be for lots of different reasons. But one could be the child is in pain or discomfort, but the other is just sick. A child is sick. Now, when I walk into a room, this is an important concept that we're going to talk about with this video. When I walk into a room, I need to decide whether a kid is sick or not sick. Now, obviously, they're in the ER. So most of the time, people come into the ER because they're sick. There's something wrong, right? And so, but when I think about sick or not sick, the term that I use as a pediatric ER doc is when someone is sick, they are, there's something I need to do right away, that they're in some decompensated state, or there is something that is not right about the child, that I want to do something right away or soon, because I want to figure out what is really going on, and sick or not sick. So the question to this group is this child sick or not sick? Do you think this kid walking into this room, looking at this child right now, is this child sick or not sick, and why? I want to finish the video, and why don't you answer that?
She is a year old.
Okay. And she looks like she likes sitting in that position. Is that the case?
Yes, she likes her legs to be kind of tucked up to her belly
Uh-huh.
and just kind of laid over.
Has she been sick in any other way? Any runny nose or fever or anything like that?
She has not had a runny nose or a fever.
Any vomiting?
Yes, she threw up twice when we got to the hospital.
Okay. Any other medical problems for Allison?
She had MRSA, and they removed that surgically from her jaw. It was an abscess, and other than that, no.
Okay. Thank you, Mom.
So what do you think? Is this child sick or not sick? What's wrong with this child when you walk into the room? If any of you have kids, Kenton says, I don't think so, because it appears like she's to be in that position for a long time. Seems like some other long-term problem. Well, sure, but in this case, this is a relatively acute issue. This child was fine. I mean, the kid sounds like had an MRSA abscess, had some surgical issue, which is here nor there. It doesn't necessarily, with one, hard to know what that really means in terms of whether there's a long-term problem. Could be. Would want to know if the MRSA abscess happened recently, because that could affect what we're talking about, and we'll get to that. Yaha said sick because she's not active and not awake. I'm with you. Not only that, but someone's reporting a respiratory rate of 36. What does it mean when a respiratory rate is high? It could mean lots of things. It could mean the child has some infectious process in the pulmonary system. It could mean that the child has a metabolic acidosis and they're breathing carbon dioxide and they're hyperventilating or breathing faster than normal because they have some underlying medical problem. So a child that is sleeping like this and has a high respiratory rate should be a slight red flag for you all that there's something wrong. Again, trying to relate the vital signs to the presenting issue. And this child now, we hear that is vomiting twice and is in this position and is not moving. Amy said, sick, needing to be consoled by mom, and that is an unusual position to be sitting in. Ding, ding, ding. Amy, you win the Star Award today because this child's position is not normal for a 1-month-old. What should a 1-month-old be doing? They're in an ER, bright fluorescent lights, there's noise. Certainly this child could be taking a nap. You could ask when the typical nap time is, which would be a great question to ask. If it's 3 a.m, we don't know what time this video was shot, but if it's 3 a.m, sure, the child could be sleeping. But let's just say, for this case, which we know to be true, it was daytime. It was certainly in the morning. It was mid-morning, right about now, 10 a.m. Pacific Standard Time. And this child's been sleeping and wakes up and cries and then goes back to sleep with a higher respiratory rate that's 36. Danielle says, because the patient's position on her belly is the most comfortable for her. Yes, that's exactly right, Danielle. And Jackie says she's in a tripod position, a history of nausea, vomiting, diarrhea, consider vital signs. Yeah, and all of that. And is actually, we don't know about nausea, but certainly having some vomiting. And we know that this child is having episodic abdominal pain. So so you walk into the room. I think one of the things that early learners do they end up making premature diagnoses, or what we call anchoring. And all of you should know what an anchoring error is. An anchoring error means that you decide that it is intussusception, or it's volvulus, or it's gastroenteritis before you consider other diagnoses. So the error would be that you say, oh, this is probably just gastroenteritis, and try to give this patient some Zofran or ondansetron, and not pay attention to what we've been paying attention to, which is that high respiratory rate, the abnormal position, the episodic nature of this. Those are all things that we're paying attention to. And something I learned in medical school at UCSF a long time ago that has stuck with me, that one of my mentors taught me, is that 90% of the time, you can make a diagnosis by history alone, without even touching the patient, without even looking at the patient. Certainly that helps, but just by observing the patient, not even laying your hands or putting your stethoscope on the patient, but just by taking a really good history, 90% of the time you can make the diagnosis. And guess what? That's true. When I have an awesome medical student or a PA student presenting to me in the ER, and they're awesome at what I consider bidirectional communication, listening and articulating to me a really good history and physical, I kind of know what's going on before I'm walking in the room, and oftentimes I'm right, probably 90% of the time, I know what's going on before I walk in the room, just because the history is so important. So I say that because it's just important to listen to the family. So in this case, we understand that this child is an ex-preemie. There's a prior incision and drainage for the skin MRSA. I would want to know when that is, when that was. Was it recently? Because we always want to consider whether antibiotics could be causing some of the problems. Why? Because antibiotics actually have side effects. Does anyone know what the top 2 or 3 side effects of antibiotics are? As a general class, doesn't matter what antibiotic or antifungal, but those infectious agents that we prescribe, does anyone know what the top 2 or 3 side effects of those agents are? Can you share with me in your question? And Jeff said GI symptoms, ding, ding, ding. So Jeff, you're right on. And nausea, vomiting, diarrhea, 20, 30, 40%, sometimes even higher, depending on what antibiotic you're prescribing. So if indeed that MRSA abscess was within a month, I would want to know what antibiotic that patient was on. They were probably either on clindamycin or Bactrim, which are the 2 most common antibiotics prescribed for MRSA abscesses. And the other thing that's really important to know is what medication the mother's been giving. Typically, this is a very common medication to give for pain. Typically, Tylenol is not so effective for pain. Ibuprofen is much of a better pain relieving agent than Tylenol. And yeah, I said lethargy, nausea, vomiting, diarrhea. Awesome. So Danielle asked, is the infant's position considered a tripod position? Not really. When I consider tripoding, I actually consider tripoding when children are up and standing like this. And they're also, sometimes we consider tripoding when they're extending their neck out like this. And I worry about tripoding. One of the conditions that I think of that's super emergent that I recently diagnosed, by the way, is epiglottitis. That should be red flag, all hands on deck. And I recognized it in a kid with that looked like it was croup in the middle of croup season, because the kid was tripoding and looking ill. And we ended up getting a lateral neck and getting the kid to the OR and probably saved that kid's life. So I actually consider what I would call this positioning, and if I were articulating this to a preceptor, I would call this positioning prone position with hips flexed. So prone position, hips flexed, and I also don't love the word lethargy. It's used a lot. I like to describe a little bit, because lethargy doesn't mean much to me. I like to describe sleepy, somnolent, easily awakens, episodic pain in the room that I witnessed or not, but that's a historical feature. Those are things that I would want to, how I would probably describe this patient's position. But Danielle, that's a great question. So I would argue that this kid is sick. I would argue this kid is sick because at this point, I haven't seen the kid move. And this child is in an unusual position and should be awake and has a high respiratory rate. And I'm thinking with vomiting, maybe this child has a metabolic acidosis or some other condition that's causing this process. So now, oftentimes, the mistake that early learners make is they actually say, well, this is what I want to do. This is what I want to do. And I'm telling some of you, many of you who are students, and I bet you Jeff is not a student. My guess is he's a practicing clinician or has been through the process. He could probably attest as well that the next step in your process, whether you're a student or whether you're practicing, should be to expand your differential diagnosis and make a good differential diagnosis so you don't anchor. That anchoring error thinking about something and excluding other diagnoses is an anchoring error and will get you into trouble and get you down a wrong path. So in this case, what is in your differential diagnosis and how would you summarize this case? I always ask the students at this point and early learners to summarize cases because it's helpful for them and it's certainly helpful for me if I'm distracted to just put it all together. And if I were to summarize this case, this is a 12-month-old female, slight premature child with a recent history of an MRSA, presenting with intermittent vomiting and pain, what seems like abdominal pain, and presenting in the prone position with the hips flexed with a high heart rate. That's sort of how I would summarize it. There are also different nuanced ways to do it, and I probably didn't do it as well as I could have, but it's sort of the essential details of what's really happening with this little young'un. And it's one of the reasons why I love children is because it's pretty easy to figure it out. So what's in your differential diagnosis? Anyone want to share in the Q&A dialogue box? What are you thinking? What are you thinking is in your differential diagnosis in this case? Any thoughts? Danielle, Kenton, Yaha, Jackie, Amy, what are your thoughts about Jeff? What are your thoughts about differential diagnoses in this case? Any thoughts? So Amy said gastroenteritis, bowel obstruction, poisoning. Those are actually some great initial thoughts. Gastroenteritis clearly needs to be in the differential diagnosis, and certainly love to see profuse diarrhea associated with that, but not always, but clearly could be early gastroenteritis. And I would put that at the top of the list, why it's very common. And we talked about what else? Any other thoughts? Well, let's release this little part of it. I think constipation should be on the list. I think intussusception can certainly be a part of the list. Bowel obstruction is a very general term, but could be from volvulus. Certainly intussusception is a form of bowel obstruction. Viral syndrome is pretty general, but almost every child on the list, we should always consider also non-accidental trauma. For example, you shake a baby and you shake their head, they could present just with vomiting, and certainly increased intracranial pressure could cause vomiting. We should be considering that in the differential diagnosis. So this is a reasonable list, and frankly, children with intussusception can present exactly like this. They can present in the prone position. Intussusception is when the bowel intussuscepts on itself and causes a bowel obstruction. So it's a form of bowel obstruction or intermittent bowel obstruction. And that's certainly something that I would put higher on the list. So considering this list, what sort of tests would you order? You're in the emergency department, so you have the ability to order a wide range of tests. This patient was seen at a children's hospital and was found to be in a place to order lots of different tests. Does anyone have a sense of what Jackie said, an abdominal ultrasound? I'm with you. Any other thoughts? Any other thoughts about tests you'd like to order? Barium enema. You know, we used to do that quite a bit. And I would say that's certainly a test you can order. That's typically what we treat this with. Although you can certainly make a diagnosis with that. Yaha said a CBC. I'm curious, Jackie, why you'd want to order a CBC and how that would change your management. I would start an IV. Typically, institutions, when you're considering intussusception, may have protocols. Sometimes, for example, at our institution at Arkansas Children's, when you have a suspicion for intussusception and you send them for an ultrasound, you actually send them with an IV. And if you're going to place an IV, I would argue that a laboratory test that would be maybe more important than a CBC would be a basic metabolic profile or a CMP. And I would also add a lipase. I always consider pancreatitis in the differential diagnosis of vomiting. Although rare, if a child's on meds, that increases the risk of pancreatitis, but something to consider. So please consider getting a CMP or BMP, especially might help you if metabolic acidosis is on your differential diagnosis. Certainly, I always like to know what the bicarb is. That is a helpful sign. And metabolic acidosis is a big word and a general concern that has many things in the differential diagnosis, including sepsis. Just generally, if someone is acidotic, that means that they're sick from a chemical standpoint, and something that you're worried about. Yaha said an ABG. It's funny that you mentioned that. I was talking about this the other day. I haven't ordered or done an ABG in probably 10 years. If we do want to get a blood gas, usually it's a VBG. ABGs are quite traumatic. Usually you get it in the radial artery. There's always a small risk of causing arterial damage. But Jeff is talking about abdominal imaging, not sure X-ray versus CT or ultrasound. And Jeff, it's funny, I think if in my world that I live in, again, I'm a pediatric ER doctor, I would do lots of things at the same time. I would place an IV because it's part of our protocol. I would probably get a CBC, although that's not as important as I mentioned, the CMP or a BMP, but I'd probably get a CMP because I always like to look at the LFTs. I'd probably get a lipase, plus or minus, but I would definitely get imaging. And I'm just efficient because length of stay is important to me. So I'd probably get a plain film image, and then I would order an ultrasound. I would not get a CT. So old school, we get CTs were more commonly ordered, especially when you consider appendicitis. But even with the appendicitis workup, which I'm not worried about appendicitis in this case yet, CT is a lot of ionizing radiation, and we're trying to avoid ionizing radiation. So I would consider getting an ultrasound. And indeed, in this case, we actually got an ultrasound, and they ordered fluids, pain control, and they did get an air contrast enema, not a barium, but an air contrast enema. Barium enemas were sort of older school. And then an ultrasound was obtained. So let's look at the ultrasound. Wow, look at that. That is an ultrasound that was done at the bedside by one of the ER physicians there. And what are we seeing? Does anyone know what we're seeing on this ultrasound? And Giselle said ultrasound, awesome, thank you. What are we seeing here on this bedside ultrasound? Can anyone share a little bit about what their thoughts are about what we're seeing? This is a specific sign that you can actually see on ultrasound, but you can actually also see it on plain film imaging. Anyone have a sense of what this is, or want to Google what this is, or what you're looking for, what the classic sign is for intussusception? Yes, Amy said target sign. Amy gets a Starbucks latte. So great job, Amy. And that is a classic target sign. You can see it on plain film imaging, and certainly can see it here. I can actually try to find target sign imaging on when I Google it. And Ryan, can you see my screen okay? With my Google searching? Yes, good. Well, I just want to point everyone, this is what the targets look like on another ultrasound, and wondering if I can see it. We have a lot of CT images, but in this film, perhaps maybe not be able to see it, but oftentimes you can see it. Actually, you could see that target sign better on this plain film imaging. So very, very cool that they were able to make this diagnosis. And this is a classic diagnosis for intussusception. And that target sign is just the sense of the bowel inside of itself. So it's intussuscepting inside of itself. The most common place for intussusception to occur is ileocecal, but you can have ileal. You can actually have colonic intussusception, usually in older people. Intussusception, just the major teaching points around intussusception. It's more common than you think it is, especially ileal. Typically, there's a viral illness. You can find by history, children usually have an antecedent viral illness because it's thought that mesenteric adenitis may be causing the lead point, but actually, I, oddly enough, described back when I was a young buck, when I was a fellow, there is an association between antibiotics and intussusception. So I was always curious about whether this MRSA in this particular patient occurred recently. So I'm a little bit more attuned to antibiotics, but outside of antibiotics and a recent viral syndrome within the last few weeks, typically intussusception is what's called idiopathic. So it's unknown. It just happens and you want to pick it up. And why do you want to pick it up? Because it's bowel obstruction. And if it's untreated, it actually can cause necrosis. For those of you that are in school right now or about to take exams, the classic finding on an exam that's associated with intussusception is current jelly stool, current C-U-R-R-A-N-T jelly. And I almost never see it anymore. Why? Because we're better at picking it up. Why? Because we're using ultrasound. I think training is better with pediatric emergency medicine and centers of excellence. I think current jelly is more of a later finding, but just again, classic exam question, current jelly equals intussusception. Should always put that higher on the differential diagnosis. But again, this episodic pain. The other interesting thing is younger children, younger than a year, could present with altered mental status. I know that sounds odd, but children who are sleepy, just not acting right, even without any of these symptoms, intussusception should be on your differential diagnosis. This case, ladies and gentlemen, is classic. This is an amazing example of how real patient video can actually imprint this into your minds. You should never forget this case because this is classic. It's classic in that it's episodic. It's classic the child presented prone. It's classic that the child is a year of age. And so standards of care, when we look at that, we do have some references for you here if you're on the ReelDx platform. And the note that was written by Dr. David Spiro, which is me, is that the position of this child and history are quite classic. This case exemplifies the need to obtain an accurate history. Look at what I wrote. I didn't even look at this before, but I'm repeating what I already said to you as I think the classic teaching points. Antibiotic use has been associated with it, and use of bedside ultrasound is an opportunity to expedite the diagnosis. And so I'm pretty brief about those teaching points. I would say that those are it. Intussusception, typically the age range is usually 4 months to 4 years. The classic mean age we know is 12 to 13 months. But if you have a child that's older, you want to start thinking about different things. I would say this is the most common form of bowel obstruction that we see in this age group, and something to consider. And there are two things I teach a lot of the emergency medicine residents who see adults as well, obviously, that you don't want to miss in kids. One is intussusception, so you want to put it on your list in this 4 month to 4 year age range, and the other is Kawasaki's disease. anytime you have fever more than 4 or 5 days. Things you don't want to miss. You don't want to anchor and put on your differential diagnosis. It would be intussusception, exactly what we talked about today, Kawasaki's disease. If you have fever for more than 4 or 5 days, it's fever of unknown origin, and you want to put Kawasaki's on your list. Does anyone have any other questions for me? Because I'm going to put this thing to a close. I've been very impressed with your answers. You all are amazing. For those of you that are in school, you're awesome. You're doing a great job. We will continue to have ReelDx Classroom as part of our offerings once a month. If you have any feedback, we'll probably send you a survey at some point, but would love any feedback from you all. If you're not using ReelDx in your classroom, would love to get it to you in your classrooms. I just love the use of real patient case video as a teaching tool. I hope that you all enjoyed this today. Ryan, do you have any other thoughts or comments that you'd like to share before we wrap this up?
No, David, you did a really good job. You know, I work with a lot of programs across the nation right now, and you're right. This is a very, very valuable tool. A lot of programs are utilizing it, picking it up, and again, thank you for your time. This is, I know, very beneficial to everybody on this call. Thank you.
Great. And with that, I will bid everyone adieu. I hope that you all have a great rest of the day. And good luck in school. We'd love to hear from you. Okay, bye-bye.
Thank you.